personal support workers and family members on the provision of needed personal care. So, we will have a three speaker. I'm going to introduce them in turn. So the first one, Jonathan Marchand, is an activist and advocate for the rights of people with disabilities. He's a senior network engineer who worked many years in Quebec and Australia for various internet service providers. He's the co-founder and chairperson of Coop Assist, Quebec Cooperative for Independent Living, which aims to create a new self-directed personal assistance program in Quebec, which will allow all people with disabilities to live freely in the community and be included in society. The model proposed is based on similar programs in Norway, Sweden, and Australia. He's also a board member of Every Canadian Counts since 2017, an organization dedicated to bring about a new insurance program to fund community-based disability support systems in Canada. And he's a member of the Council of Canadians with Disabilities Ending of Life Ethics Committee, which aims to develop and implement strategies for promoting a disability right perspective on how to preserve and advocate for the human rights of people with disabilities in an environment where medical aid in dying has become available. So in that sense, he shares some interest with myself and the other speakers. The second speaker is Amy HASBROUCK, who's been a disability rights activist for more than nearly 40 years. And her activism combines her personal experience with congenital and acquired disability with a cross-oppression analysis gained through involvement in the women's rights, anti-war, LGBT, and other social justice movements. She worked in architectural access and the independent living movement before graduating from Northeastern University School of Law in 1997. And her subsequent legal work concentrated on health and mental health law and implementation of the Americans with Disabilities Act. So she's produced different kind of work, some groundbreaking report on prosecution and sentencing of parents who killed their disabled children in 1997. And that study led her to be involved with the disability rights-based opposition to assisted suicide and other end-of-life practices that may discriminate against people with disability. She's served on the board of Not Dead Yet in the US since 2000, and she's the founder in 2013 and the executive director of Toujours Vivant, Not Dead Yet, a project of the Council of Canadians with Disability to expand the reach of CCD's Ending of Life Ethics Committee, to which Jonathan belonged. And our third speaker, HEIDI JANZ. Dr. JANZ specializes in the field of disability ethics. She's been affiliated with the John Dosseter Health Ethics Center since 2006. She's currently an assistant adjunct professor with the John Dosseter Health Ethics Center. She was employed as the curriculum coordinator for an emerging certificate in disability ethics in the Faculty of Rehabilitation Medicine at the University of Alberta. She's also a writer and a playwright and published a novel for young adults, and her list of produced plays are very impressive and have been produced on the stage, such as the Edmonton Fringe in the summer of 2001. She has also worked, like our other speakers, in relation to the care of the terminally ill. So our three speakers are very well placed to understand the ethical, political challenges facing people with disabilities in a situation where health and life is threatened and where health resources are limited. So without further ado, I will pass. I will let Amy HASBROUCK take over. If you want to go first, Amy.
Yeah, thank you. I'm going to try to share my screen, and hopefully that will work. And maybe, oh, I got to click share. Okay. Oh gosh. Okay, so this is interfering with my. All right. The COVID-19 pandemic has had a disproportionate impact on people with disabilities and people of color. This is partly due to the lower value placed on the lives of disabled people and racial and ethnic minorities. The highest casualty rates have occurred in nursing homes, prisons, and other institutions. Among residents, who are predominantly people with disabilities, regardless of age, and among workers, especially women and racial and ethnic minorities. And people who work in low-wage jobs, especially personal support workers and agribusiness, are overrepresented among those infected because of cramped and unsafe living and working conditions and lack of infection control procedures and protective equipment. Prisons have become a common custodial setting for persons with cognitive and psychiatric disabilities, and Black and Brown Indigenous people are overrepresented in the prison population. Physical distancing is impossible where multiple prisoners occupy a cell. Quarantine procedures have disrupted home-based supports, such as personal care and homemaker services, and other services that enable people with disabilities to live in the community, like home delivery of groceries and medications, often charge a fee or are overwhelmed or unavailable. Disabled people are mostly excluded from policymaking in response to the pandemic. And though the federal government has appointed a COVID-19 disability advisory group to provide policy guidance on issues related to the pandemic, none of the provinces has included disability activists in their pandemic response teams, and that's especially apparent in Quebec. The pandemic has both highlighted and worsened the problems of warehousing people in institutions that we've known about for 60 years, since the exposure of conditions at the Huronia Regional Center in Orillia, Ontario in 1960, and Jonathan is going to talk about that, so I'm just going to skip right down to the next section. Other problems related to the COVID-19 policies that have been implemented since the beginning of the pandemic. One of the policies that has been implemented, especially in Quebec, has been to increase wages for institutional employees to make up for staff shortage. But that has lured workers away from providing home-based care, and that has created its own problem. Proprietary software and digital locks make it difficult to repair or adapt ventilators and other essential medical equipment. People whose health deteriorates due to poor quality care, such as insufficient time to eat or poor wound care, are often placed on palliative care regimes, where food and water and other medical treatments are withdrawn, whether or not they have COVID-19. And so basically a lot of people are left to die that way. And medical assistance in dying, which is classified as an elective procedure, continue to pay despite the suspension of other elective procedures. The United Nations and Government of Canada each released policy statements on COVID-19 and disabled people. The UN document emphasized the rights of disabled people and suggests specific actions regarding healthcare, people in institutions, community living, income and employment, education, domestic violence, homeless people, and prisoners with disabilities. The Government of Canada's recommendations focus on support for vulnerable populations and are not very substantive. Ontario and Quebec issued triage policies which drew fire from disability rights organizations for lack of consumer input in their development, and because the protocols violated principles of non-discrimination, such as those described in the evaluation framework for crisis plans developed by some disability organizations in the United States. Both the Ontario and Quebec procedure protocols mention specific disabilities such as cognitive impairments, Parkinson's disease, amyotrophic lateral sclerosis, and cystic fibrosis as criteria for exclusion. While neither protocol uses quality of life measures per se, both use the clinical frailty scale as a measure of a person's overall health based on their ability to independently perform certain activities of daily living, which is a no-no. Both protocols use potential for long-term survival as threshold eligibility criteria, which puts people with chronic illnesses and disabilities at a disadvantage for getting treatment and fails to account for the significant uncertainty surrounding long-term survival probabilities. And institutions have found a way to get around the triage protocols. Though officials assure the public that the worst case scenario that would invoke the triage policies won't happen. However, that policies are only invoked if there is a substantial strain on the healthcare system, but there is no strain on the system if nursing home residents with COVID-19 are not sent for aggressive treatment in intensive care unit. This is de facto triage by age and disability. And this is a really important point because they're assuring us, don't worry, these triage protocols won't be invoked, but the reason they're not invoked is because people are being left to die. However, there is hope in fighting back. Nobody is Disposable is a coalition of queer, fat, disabled, and people of color who have challenged discriminatory policies and created educational material. The Black Lives Matter movement has amplified the voice of disabled people of color. Especially active in that is Anita Cameron with Not Dead Yet in the United States. She's the multicultural outreach coordinator, as they speak about the intersectional nature of racism and disability discrimination. And in response to criticism, the Ontario triage protocol, it was withdrawn but has not yet been replaced. Quebec's triage protocol is being challenged by advocates who have launched a petition asking for it to be withdrawn. And finally, communication and accessibility options have expanded through the adoption of more flexible employment practices, such as working from home and online meetings. So the isolation that disabled people live with all the time has now become the norm for everybody else.
Unmute. Okay, great. So thank you, Amy. So I'll put on the chat a link to a petition in relation to that Amy was talking about, so that those interested in signing the petition and getting more information, the petition being against the triage protocol in Quebec that could be problematic, it will be in the chat. Also, if you want to ask questions to everyone, yes, I will immediately. Yeah. If you want to provide a question either privately to me or to the speakers, or to me addressing the speaker, I'm taking notes of any question you may have, and we will have question period immediately after the talks. And so the second speaker is HEIDI JANZ. Heidi, do you want to go? I'm going to pass it over to you.
Okay. The COVID-19 pandemic has thus far been punctuated by reports of ableism in action. Of course, these events have almost never been reported on as instances of ableism. Rather, they've been presented as unfortunate consequences of healthcare systems being pushed beyond their breaking point by the pandemic. Among the most disturbing of these reports have been stories of COVID-19 outbreaks in long-term care facilities and group homes, causing personal support workers and healthcare aides to fall ill themselves, and prompting those who remain to abandon their elderly and disabled clients. Interestingly, and tellingly, while the deplorable conditions of seniors languishing in long-term care facilities has, rightfully, garnered national attention in recent months, the abandonment of physically and developmentally disabled adults by staff at Participation House, a care home in Markham, Ontario, in April, was little more than a blip in the 24-hour news cycle. For both the mainstream media and the general public, there appears to be a clear qualitative distinction between the physically and developmentally disabled residents of Participation House and the, mostly, senior residents living in long-term patients with COVID-19. All of these things point to the fact that Canada suffers from a pre-existing condition that is making COVID-19 much more lethal for entire segments of its population. The name of this condition is ableism. Disability scholar Veronica Chouinard defines ableism as ideas, practices, institutions, and social relations that presume able-bodiedness, and by so doing, construct persons with disabilities as marginalized, and largely invisible others. Canadian disability scholar Gregor Wolbring notes that ableism and preference of certain abilities has been rampant throughout history. Ableism shaped and continues to shape areas such as human security, social cohesion, social policies, relationships among social groups, individuals, and countries. Ableism is one of the most societally entrenched and accepted isms. I find Professor Wolbring's summary of the all-encompassing scope of influence that ableism has in contemporary Western society to be quite accurate. Clear, yet unacknowledged, evidence of ableism can be seen in everything from the way in which buildings are built to exclude people who do not walk or see, to the way in which students with disabilities are taught that it's better to look, move, and behave as much like their non-disabled peers as possible, to the way in which terms associated with disability are used as insults in common parlance. Unlike sexism or racism, however, ableism remains a largely unacknowledged form of discrimination. Healthcare has traditionally been viewed as a benevolent discipline in which every human life is valued equally, without any form of prejudice or discrimination. While this may remain the ideal to which healthcare aspires, the reality is that, as individuals, healthcare professionals are not immune to the influence of dominant societal understandings of, and attitudes towards, individuals and groups of people deemed to be others. Ghali and colleagues observe that despite their intentions, personal goals, and normative expectations, even health professionals are unconscious bearers of implicit social biases that affect the quality of professional interventions. They further contend that, immediately, and from early life and thereafter, people perceive individuals with disability as vulnerable and of low competence and, accordingly, treat members of this group differently. Despite the major role that medical professionals play in the lives of people with disabilities, research indicates that people with disabilities frequently encounter discrimination in healthcare settings, even in ordinary times. Studies have consistently shown that, as a group, healthcare professionals tend to substantially underestimate the quality of life of people with disabilities. Such erroneous judgments about the quality of life experienced by people with disabilities can result in treatment options for people with disabilities being either limited, or altogether eliminated. At the heart of such decisions is what disability scholar Joel Reynolds has termed the ableist conflation of disability, suffering, and death, wherever operative. The ableist conflation flattens communication about disability to communication about pain, suffering, hardship, disadvantage, morbidity, and mortality. What makes medical ableism so dangerous and so insidious at the same time is that it often presents as common sense. James Cherney argues that ableism is that most insidious form of rhetoric that has become reified and so widely accepted as common sense that it denies its own rhetoricity. It goes without saying. Within this milieu of common-sense ableism, people with disabilities are routinely made vulnerable in medical settings. For example, studies have consistently shown that the emergency department environment can be stressful, and even dangerous, for people with developmental disabilities and/or communication disabilities, both because deficits associated with these conditions hamper these individuals' ability to communicate their concerns, and because staff often do not have the skills needed to work with them. The advent of COVID-19 has only exacerbated these stresses and hazards, sometimes with lethal consequences. The tragic death of Arius Knight in April powerfully demonstrates the real and present danger that medical ableism poses for people with disabilities in the wake of COVID-19. Knight was a 40-year-old BC woman who had cerebral palsy. She was nonverbal, but could communicate with her family and aides through facial expressions, which they had learned to recognize and interpret. She died of a respiratory illness on April 18, a few days after she was transferred to the hospital from the group home in South Surrey where she had lived for a decade. Because of COVID-19 visitor restrictions, none of Knight's caregivers or family members were allowed to be with her in the hospital, and she died alone. Even prior to COVID-19, many people with disabilities, especially those with communication disabilities, have been fearful of going into emergency because their support people may not be allowed to stay with them. Arius Knight's death, and the circumstances surrounding it, sparked an outcry from disability rights advocates across the country. The newly appointed Federal COVID-19 and Disability Advisory Group, CDAG, presented an urgent recommendation to the Federal Minister of Health that she strongly encourage her provincial and territorial counterparts to revise their hospital visitation policies so as to designate family members and support workers who provide care and assistance to a patient with disabilities as essential visitors. While the Federal Minister of Health did agree to take this recommendation forward to her provincial and territorial counterparts, to date, I have only been able to confirm that visitor policies have been amended to adopt this recommendation in British Columbia, Alberta, Saskatchewan, and Ontario. Although this may be an incomplete list, it nevertheless speaks to the fact that recognition of the right of people with disabilities to have access to their personal support people in medical settings during this COVID-19 pandemic remains far from being universally guaranteed across Canada. For the first 2.5 months of this pandemic, we heard our Prime Minister, Premiers, and officers of public health join in unison with their counterparts around the world to repeat the mantra, flatten the curve, protect the vulnerable, stay home. The optimists among us may have been tempted to point to this as a sign of a resurgence in the value that our society attributes to the lives of vulnerable seniors and people with disabilities. The extreme optimists among us may have even been tempted to wonder if the pandemic could possibly become a catalyst for the reclamation of the notion of a common good as the core ethic of our society. Ethicist John Rawls defined the common good as certain general conditions that are, equally to everyone's advantage. Ironically, in the decades leading up to this current pandemic, the notion of the common good as a viable ethical principle had, for all intents and purposes, become obsolete due to the rise of autonomy as the cardinal ethical principle in Western societies. Yet, the advent of COVID-19 seemed to bring with it a renewed recognition of the viability, indeed, the necessity, of upholding the common good as a guiding ethical principle to ensure our survival as a society. Unfortunately, however, other developments we've seen during this pandemic sharply undercut such optimism. Early on in this pandemic, in many provinces across Canada, we saw the release of critical care triage protocols which provide guidance for the allocation of critical care resources, i.e. ventilators, should they become scarce due to an overwhelming surge in critically ill patients with COVID-19. As these protocols became public, it became evident that the vast majority of them listed pre-existing disability as an exclusion criterion in the event that rationing of critical care resources becomes necessary. Again, disability rights advocates across the country, as well as the CDAG, were quick and persevering in sounding the alarm regarding the blatantly discriminatory nature of these protocols, and the extreme danger that they pose for Canadians with disabilities. Again, these concerns were relayed from a federal to a provincial level. Unfortunately, while the response on the essential visitor policy has been inconsistent, the response on discriminatory critical care triage policies has been virtually non-existent. So, where does all this leave people with disabilities still in the midst of the pandemic? Unfortunately, I think that, to a great extent, the answer to this question is found in a distinction that I alluded to at the beginning of this presentation. That is, the distinction that both the mainstream media and the general public are making between seniors in long-term care facilities, who are regularly, collectively referred to as our parents, or our grandparents, versus younger adults with physical and/or developmental disabilities, who, although they are likewise warehoused in congregate care facilities, do not share the senior's status as once having been non-disabled, contributing members of society. People with disabilities thus continue in essentially the same position that we were in before the pandemic, on the margins of an ostensibly inclusive society.
Sorry. Thank you so much, Heidi. So we'll move to our last speaker, Jonathan Marchand. I hand it over to you.
Thank you, Jonas. All right. So, all right, institutions, segregation, and a way forward. Now, I was introduced by Jonas. I've been forced to live inside a long-term care facility for about 10 years now. I've been fighting for years to get out of here. Now, in Quebec, there are two worlds. Premier Legault has described during his addresses how people with disabilities and the elderly are segregated in Quebec. On one side, you got the old, the disabled living in nursing homes throughout the province who are dying by the thousands. And on the other end, you got the real citizens who contribute to society and live in the community. Now, there's about 70% of people with disabilities who need personal assistance who live in institutions in Quebec. For most, there's no way out. It's a final destination. You enter a facility and you don't come out alive. And euthanasia is offered as a solution by this government. Now, what does it mean to be warehoused into an institution? Basically, you got no choice or control over where you live, how you live, and with whom you live. You got no choice over who touches your body to provide you with assistance. During the many years I've been inside, I've been handled by thousands of different people. It's incredibly dehumanizing. You can't have a normal family life. Basically, you can't live with your partner, with your kids, or have any kind of normal life. You cannot work and invest in your future. You will remain poor and it will make you poor. The system is designed to siphon away all the wealth that you have. Now you have no spontaneity or flexibility in your life. They will tell you at what time you get up, what time you go to bed, what time you go to the toilet, what you eat, at what time you eat. Basically, everything is scheduled and timed. A file is kept on you. Basically, all your private life can be cataloged in that file. And institutions are a violent environment. There's violence at all levels. There's violence between the patients, the residents, between the staff and the residents, there's lots of bullying among the staff, and the managers as well can be victim of violence, and you will endure systemic and organizational abuse. Now, what does it mean? It means that you lose your citizenship. You become an object of care and profit. So you live in some kind of weird dystopian nightmare. Now, COVID-19 and the equal chance of survival. Um, Now, you got no way to ensure your own safety inside the facility. You got to wait for the government to come and save you, which is pretty much the worst survival strategy. You got no choice or control over the environment and the staff. There's a chronic understaffing inside facilities. It's been ongoing for years, even decades. Staff is shared amongst many residents and facilities, so the virus can be spread very easily between units, between facilities. It's incredibly dangerous to have a shared service like that. There's a poor infection control. There's lack of testing. Even today, many workers have not been tested up to a third, and there's no testing regimen in place. So it's a big issue, and protective equipment is also an issue in some places even now. A pre-symptomatic worker can infect dozens of patients and workers as well. So and we've seen many facilities get infected like that. And there was some disastrous caregiver restrictions at the beginning of the pandemic, which led to the dark death of many people, many residents, and it was completely unnecessary. I mean, in BC, they did not restrict essential caregivers, and they fared much better than in Quebec. And at the end of the day, you're 17 times more likely to catch the virus inside the facility than if you were living in the community. And the healthcare workers are spreading the virus in the community now. So it's no longer just a human rights issue, it's a public health issue. Long-term care facilities, institutions are a threat to the whole society. Now, how did we get there? We got a strong culture of dependency in Quebec. Basically, people with disabilities and the elderly are seen as vulnerable and sick. Now, when you're defined like that, when you're labeled like that, you got to be taken charge of. We need to protect you. We need to decide for you, which is incredibly toxic. And you become an object of pity and charity. And one of the reasons this culture keep on going is that there's lots of internalized ableism and ageism. Basically, when we tell you that it's your fault, it's your disability, the problem, you are the problem, you are a burden, it's easy to internalize these feelings and start to believe them. And there's this misconception that there are good institutions, that we just need to fix the institutions and everything will be fine. But it's not. It's the worst solution, actually. And these places deprive the freedom of people with disabilities and the elderly. And there's a huge institutional bias in our system. Basically, all the funding goes toward institutions instead of home care services. So up to 90% of the funding goes toward institutions. Now, the community living is the answer so that everyone can be safe. I've been working on implementing a program which we call the self-directed personal assistance program, which would allow all people with disabilities to live in the community and choose where they live, how they live, and with whom they live. It's a cooperative by and for people with disabilities. We've been lobbying the government for a few years now to make it happen. However, the government would just want more institutions. They invested pretty much all the money into new institutions for people with disabilities. And there's also a proposal on the table at the federal level to create a new insurance program that would allow people with disabilities to live in the community, because the issues we have in Quebec are the same throughout Canada. Now, there's maybe an opportunity for a reform of our support system for people with disabilities. Now, the starting point for that would be that the new system would have to be compliant with the United Nations Convention regarding the rights of persons with disabilities and our Charter of Rights. Everyone needs to have the choice of where and how they live, with whom they live as well. And the conversation we need to have is how do we reduce the number of beds in institutions and eventually close them down and abolish them. Oh, thank you.
Unmute myself. Great. Thank you so much to Jonathan and our three speakers. Because of the interruption, we will not have a lot of time for questions, but please do feel free to ask them to the in the chat, and I'll convey them, and our speakers can tackle them. One of the I think one of the issues that I've seen coming up with the chat, some of them addressed privately to me, some of them public, was I think there's a sense that there is a gap between, on the one hand, legal norms like the CRPD, the UN Convention for the Rights of Persons with Disabilities, and the Charter of Rights and Freedom, and the reality in which we live. And there seems to be an aspiration to do more, but it's so one person was wondering what possible legal recourse or class action could be started so as to force entities, may they be government or universities or whatever other institutions, to provide the need to provide what is being asked for. And so I have my own thoughts about this, but I would be curious to hear about your thoughts about the gap between aspiration and practice, and how optimistic we could be about potential legal recourse or pressure or lobbying. I think you've addressed different aspects of it in your talks.
If we look at what happened in the United States, there's the Olmstead decision, which was groundbreaking because it allowed many people with disabilities to leave their institutions and get assistance to live in the community. And maybe Amy could expand on that, but it's definitely legal recourse can lead to change. However, it's often pretty slow, and there are other ways to get there as well. There's direct action, there's lobbying, there's many things that can be done. But if we do nothing, nothing's going to change, that's for sure. And there's lots of resistance to change. In Quebec alone, the industry to warehouse people with disabilities and control their lives is worth about $10 billion. So there's lots of people who don't want any change. They just want to keep on going the way it is. And we need a government that's resolute to change those things. It takes political will to do it. Without that, it's very difficult.
Yeah, this is Amy. I would just add that the organization in the United States known as ADAPT started out as a group advocating for accessible public transportation, but in 1990, with the passage of the Americans with Disabilities Act that provided reinforcement for the accessible public transit mandate, ADAPT changed its mission and began to pursue attendant programs and deinstitutionalization as its primary and exclusive focus. And it was the direct action of ADAPT that reinforced the legal efforts that led to the Olmstead decision in 1999. And the Olmstead decision basically was the Supreme Court of the United States saying that the Americans with Disabilities Act requires that people be allowed to live in the least restrictive environment possible. Now, that's a very important decision. And the fact that in Canada, that healthcare is managed by the provinces is very detrimental to any national organizing. And it's been very difficult to organize. It's always difficult to organize disabled people because A, we're isolated, B, it takes so much energy for us to get out. B, we don't have personal assistance services to enable us to get out and go to meetings. And we don't have accessible transportation oftentimes to get out to meetings. And so the direct action has been extremely difficult. And the organizations that are made up of people with disabilities are primarily focused on just accessibility stuff and at all.
Sorry, Amy, I don't know if it's just me, but just the very last sentence, it seems to have bugged. At the end, you said the disability organizations are mostly concerned with access issues instead of...
and they're not focused on deinstitutionalization or access to community supports as a primary focus.
Yeah. And the claim that the three of you have been making in different ways is that the institute is that bringing care to home or finding alternative solutions. The resisting that move is in great part motivated by ableist assumptions and by a desire to segregate a threat of some kind. And it's not even economically rational. Some of the audience members have been mentioning when they speak of forcing governments or universities to take action for to treat people equally, and not doing so is even odder if there is no justification other than prejudices.
I would also emphasize the feminist nature of this issue because especially Quebec, but also in other provinces, there's an assumption that aidants naturels, people's family members, will provide free personal assistance services to folks with disabilities. And that is a feminist issue, obviously, because people should be able to choose who provides personal assistance, and B, should be able to have personal assistance that doesn't interfere with their intimate relationships. So if I need personal assistance, I should be able to hire somebody who is not my husband to provide that assistance if that is my choice. And that is not something that is at all envisioned in Canadian society.
Mm-hmm. Yeah. So from then from a legal perspectives, there are a few rights at stake. Again, to go back to some of the questions we got, there's the right to privacy, right to life, a right to be treated equally by the government, to be equally protected under the law, and other rights in human rights conventions, and so all of those would be violated by treatments that belittle individual autonomy. You seem to say that really limits the autonomy. That's what I've heard a great deal this this afternoon. I'm sorry. And so, we have the time for one more question. If someone in the audience wants to, you can virtually raise your hand. There's a little function to raise your hand if you know about Zoom. If you want to speak directly, or to use, and then I can unmute you, or to use the chat. Or to use the chat to ask one more question if you want. Otherwise, so feel free to do so. Otherwise, I will ask the speakers if they have any parting thoughts that they want the audience to leave with. Jonathan, Heidi, or Amy,
Yeah,
if you do, yeah.
I think there's a few questions in the chat. So Tanya, I have a question.
Read the chat, so go
Yeah,
ahead.
is there a possible legal recourse? Yeah, we answer that.
I think Heather asked, do you see the cooperative as being the employer of support workers?
Yeah, well, the model we're proposing is, well, first of all, people will have the choice. So if someone can and want to manage everything, they can. They can create their own small business and manage everything, all the accounting, and be the direct employer. But with the cooperative, what we're proposing is that the cooperative officially will be the employer of the workers. However, the members will have full control over their services. So if there's an issue, if someone needs support to manage their assistance, the cooperative can help with that. If there's a conflict, if there's help needed to recruit or workers, we can help as well. So it shields the members from some of the responsibilities from being the direct employer, that the cooperative is there to help them choose and respect their wishes. It's a model that exists in Sweden, in Norway, in Finland, in Iceland, and I think we think it could work very well in Quebec.
Actually, I live in Alberta.
I live in Alberta.
I live in exactly.
And I live in a building exactly like this. We are a mixed building. But those of us that require attendance, we manage our services cooperatively.
Okay. Well. Okay. So so we're at the end of the webinar, but I just wanted to thank the speakers, and to note in response to what's been mentioned, in response to what you've just been saying now, the speakers, so Tanya was mentioning to everyone how this is in part an issue of valuing the lives of people with disabilities and older adults, and so that is an issue that we've touched on today, certainly. So I think I thank our speakers very much for their generosity, for sharing their insights, and I'll certainly leave this with some food for thought myself, and I hope that you all will. And yeah, so I wish you a good rest of the day, and do not hesitate to communicate with any of us if you wish to do so. Thank you.
Thanks, everyone.
Thank you.